discuss prolactinoma. Too much prolactin. Prolactin favors lactation. Are you against lactation? No, I favor lactation. I'm a prolactin. What's the function of the prolactin? It fills the breast with it fills the breast with milk. It favors lactation. Prolactinoma is whenever you have a pituitary adenoma secreting prolactin. Prolactinoma is the most common pituitary tumor. The most common pituitary tumor is prolactinoma. When you have a pituitary tumor that secretes too much prolactin, what are going to be the presentations? Well, men will present late because the major presentation of hyperprolactinemia in men is going to be impotence, decreased libido, and occasionally gynecomastia. So this is not going to drive men to the office or to seek medical advice fast. But look at women. The presentation of prolactinoma is what? Amenorrhea, missed period. So the lady will think that she was pregnant and definitely will come and seek advice. And galactorrhea in absence of pregnancy. So amenorrhea and galactorrhea in the absence of pregnancy are the early manifestations of a prolactinoma in women. Men will usually stay late and present late, and by the time they have presented, the tumor has reached such a big size that it can result even in some visual disturbances, headache and visual disturbances. Prolactin inhibits the gonadotropin releasing hormone. If there is no gonadotropin, the body cannot release LH and FSH. That's why the most common cause, or not the most common cause, the most common physiologic cause of high prolactin is pregnancy. Prolactinoma should only be investigated under the following conditions. Number one, you have a patient with prolactin excess manifestations. Number one, you have to exclude pregnancy. When it comes to prolactin, prolactin is kind of an exceptional endocrine disorder that it can be caused by different causes. So hyperthyroidism cannot be caused except by problem in your thyroid, too much thyroid hormone. Cushing, too much cortisol, nothing else will result in this. But when it comes to prolactin, a lot can increase your prolactin. Pregnancy is number one physiologic cause. Some drugs can increase your prolactin. Metoclopramide, phenothiazines, tricyclic antidepressants all increase the prolactin level. If the prolactin level is very high, really high, more than 200, then you should investigate for a prolactin adenoma in the pituitary. Other causes of hyperprolactinemia like hypothyroidism. Can you believe that? When you have hypothyroidism, your prolactin level is going to go up, because in hypothyroidism, what comes out from your hypothalamus? Thyrotropin releasing hormone. And thyrotropin releasing hormone in hypothyroidism will lead to increased prolactin secretion. Nipple stimulation. People who have piercings at their nipple, this will result in nipple irritation, and this will result in elevated prolactin levels. Stress, exercise can increase prolactin. So don't start with a pituitary adenoma. Start first by excluding these causes. Then if you excluded these causes and your prolactin level is really high, search for a pituitary adenoma. So the most accurate diagnostic test is MRI of the brain to look at the pituitary adenoma. Again, I say, don't start with the radiological tests in endocrinology. The radiologic tests are never the most accurate tests when it comes to etiology, because guess what? There is a considerable percentage of the population who have asymptomatic pituitary adenomas. Asymptomatic, non-functioning pituitary adenomas. So see if you started by scanning the pituitary. Hey, you have a pituitary tumor, I should get it out. And you get the pituitary tumor out, and the patient did not have any endocrine disease. And this pituitary adenoma was not supposed to be taken out of the body. The treatment of prolactinoma The best initial therapy actually is for pharmacologic therapy. We give a dopamine agonist agent. Why dopamine agonist? Because dopamine in our body is the normal inhibitor of prolactin secretion. What inhibits the prolactin secretion from your pituitary is the dopamine that is coming from your hypothalamus. Your hypothalamus secretes dopamine to inhibit the pituitary production of prolactin. And this is what we're going to do when we treat hyperprolactinemia. We're going to give you a dopamine agonist agent like bromocriptine, or more commonly used cabergoline. Cabergoline is more commonly used, and most prolactinomas can be corrected by these medications. Surgical removal is indicated in the small number of patients where the medical therapy fails. So the key features of our case study about hyperprolactinemia: we have a 24-year-old woman presenting to her gynecologist 5 days after missing her period that used to be regular. See, females usually present earlier when they get hyperprolactinemia. Men present late. There has been a small amount of milky discharge from both breasts noticed about 2 weeks ago. The patient was not using any contraception method, but she has not been able to get pregnant. So, what are the clinical manifestations that are consistent with the diagnosis of hyperprolactinemia? There are two clinical manifestations consistent with the diagnosis of hyperprolactinemia: galactorrhea and menstrual irregularities. Galactorrhea and a missed period, these are the most important manifestations. What is an appropriate diagnosis for this patient? Since elevated prolactin concentrations are not apparently caused by pregnancy, medications, pituitary, prolactinoma, head trauma, a prolactin secreting tumor of the lung, or compromised renal or hepatic function, a diagnosis of idiopathic hyperprolactinemia is appropriate. Sometimes even the pituitary has no adenoma, then we are only left with a diagnosis of idiopathic hyperprolactinemia. What's an appropriate initial approach to therapy for this patient? As I said, cabergoline, the dopamine agonist, and monitoring the patient for a neuroimaging evidence of a developing prolactinoma is also appropriate. Has response to therapy been positive in this patient? Actually, we noticed decline in her serum prolactin. She's responding. Had the patient's prolactin level normalized? Actually, no. The normal level is when it is reduced less than 20 nanograms.